Hello everyone and welcome to this lecture on cell and blood disruptors, that is beta-lactam antibiotics. Today we are going to see about that, starting with the part 1 of this lecture. So we all know these are the various mechanisms of actions of various antibiotics. Some of them are inhibitors of metabolism such as sulfonamides, trimethoprim, and there are inhibitors of cell wall synthesis such as beta-lactam antibiotics, which we are going to study today. Then there are inhibitors of protein synthesis such as aminoglycosides, inhibitors of nucleic acid function or synthesis such as fluoroquinolones or rifampin or rifampicin. Then there are inhibitors of cell membrane functions such as amphotericin B or isoniazid. Okay, so then let's start with the beta-lactam antibiotics. In beta-lactam antibiotics, there are four kinds of antibiotics. First is the penicillin, second is the cephalosporins, then there are monobactams and carbapenems. Okay, so these are the four important types of beta-lactam antibiotics. Today we are going to see the penicillins. So first of all, let's see that the beta-lactam antibiotics, all of them, all four kinds of beta-lactam antibiotics share a common structure, that is the beta-lactam ring. Means all these penicillins or cephalosporins, they all have beta-lactam ring, and that is why they are known as beta-lactam antibiotics, and they share the same mechanism of action, that is they inhibit the synthesis of bacterial peptidoglycan cell wall. So they are the cell wall synthesis inhibitors. So the bacterial cell wall contains the peptidoglycans, and the gram-positive microorganism, they have a 50 to 100 molecule thick cell wall, while the gram-negative bacteria have only 1 to 2 molecules thick cell wall. Let's see that. These are the gram-positive bacteria cell wall, and as you can see that there is a multiple layer of peptidoglycan. Okay, so they have a thick cell wall, while the gram-negative bacteria, they have a single layer peptidoglycan layer, as well as of course there is an outer membrane which contains the poring channels. Okay, so this outer membrane and peptidoglycan layer combinedly compromises the cell wall. Okay, so they combinedly form the cell wall. And as you can see in the plasma membrane, there are penicillin binding proteins. Okay, this is an important term, that is penicillin binding protein or PVP. So here you can see the peptidoglycan layer. It composed of two uh, amino sugars. First one is the NAM and second one is the NAG. NAM is the N-acetyl muramic acid, while the NAG is N-acetyl glucosamine, and these two amino sugars are arranged alternatively, and so here is the NAG, NAM, NAG, NAM, and this forms a chain. This is the glycopeptide polymer outside the cell wall, and here is one more chain here. Okay, so these are the two chains and they are cross-linked by the peptide chains. Okay, so they are cross-linked by the peptide chain. Okay, these are the peptide chain, and they cross links these two amino sugars chain. Okay, and these are amino acids L-alanine, then there is the D-glutamate, L-lysine, and D-alanine. Same here, it is L-alanine, D-glutamate, L-lysine, D-alanine, D-alanine. Okay, and they are cross-linked by the bridge. Okay, this bridge is of 5 glycines. Okay, so this bridge composed of 5 glycines. Okay, so this bridge is formed by this very important PVP or penicillin binding protein, which is known as transpeptidase. So this transpeptidase penicillin binding protein forms this bridge. Okay, and this bridge is formed between this fourth D-alanine with the third of L-lysine. Okay, so when this transpeptidase works, one D-alanine is removed from here, and this fourth one D-alanine, that is 1, 2, 3, 4. So fourth D-alanine is joined with the third L-lysine. Okay, with the glycine bridge. So that's how this structure, this peptidoglycan layer is formed, and this last step of transpeptidase of forming this bridge is very important for this peptidoglycan layer formation in the bacterial cell wall. So now what really happens is that this is the NAG, and the NAM and NAM are joined with the peptide chain, and this cross-linking of adjacent peptidoglycan strands by the process known as transpeptidation, means transpeptidase enzyme form this bridge, and this process is known as transpeptidation. Okay, and this last step, this process is blocked by the penicillins. Not only penicillins, all beta-lactam antibiotics, they just inhibit this process, and because of that the peptidoglycan layer formation is inhibited, so the cell wall of those bacteria is weak. Okay, and because of that our immune system can work better on those bacteria. So the main mechanism of action is the bacterial cell wall synthesis inhibitor of all beta lactam antibiotics, and that is why they all are bactericidal. Okay, because we now know that the cell wall of these bacteria consists of peptidoglycan, and this peptidoglycan formation, peptidoglycan synthesis is inhibited by these bacteria, sorry, by these beta lactam antibiotics. So the beta lactam antibiotics are peptidoglycan synthesis inhibitors by inhibiting the penicillin binding proteins such as transpeptidase. Now we know that these bacteria may develop resistance to these beta-lactam antibiotics, and the major mechanism of action of this development of bacterial resistance is the production of beta-lactamase. This beta-lactamase is an enzyme which is produced by the bacteria, and these beta-lactamase enzyme, they hydrolyzes the bond in the beta lactam ring. So the all beta lactam antibiotics consist of beta lactam ring, and this beta lactam ring is hydrolyzed by these beta lactamase. Okay, and there are other mechanisms of bacterial resistance such as decreased permeability to the drug. That is how also they may develop bacterial resistance. uh, uh, the bacterial outer cell membrane uh, is uh, is developed in such a way that the uh, beta-lactam antibiotics will not be able to penetrate this outer cell membrane of the bacteria, so the beta-lactam antibiotics will not be able to reach to the penicillin binding proteins, and if they will not be able to reach to the penicillin binding proteins, they will not be able to inhibit the transpeptidase enzymes, and they will not be able to inhibit the peptidoglycan layer synthesis. Okay, as well as there are some efflux proteins also. Okay, some bacteria may develop efflux proteins, and because of those efflux proteins, the beta lactam antibiotics, which is trying to enter into the cell of bacteria, they will be effluxed out. Okay, this reduced penetration of the drug into the cell is of greater concern, particularly in some gram-negative organisms which have complex cell wall. Okay, so that is how all that happens, as well as one more mechanism of bacterial resistance is the altered penicillin binding proteins. Okay, some bacteria may develop the penicillin binding proteins with lower affinity to the beta lactam antibiotics. So the beta lactam antibiotics will not be able to attach to the penicillin binding proteins, and they will not be able to inhibit those penicillin binding proteins. Let's see an example. What is this? We may have come to know this. This is Augmentin 625 Duo. This is a very commonly used antibiotic. It consists of amoxicillin, one very important beta-lactam antibiotic, one very important penicillin, and it is combined with clavulanate. What is this? We will see that beta-lactamase inhibitors. What really happens is that we know that the major mechanism of bacterial resistance is the production of beta lactamases by these bacteria. So what we do, that we combine the beta-lactam antibiotics with beta-lactamase inhibitors. These beta-lactamase inhibitors inhibits the beta-lactamase enzyme of the bacteria, and we will have the greater activity of our beta-lactam antibiotics, such as when we saw that amoxicillin is combined with clavulanate. This clavulanate is one very important beta lactamase inhibitor which is commonly used. Okay, these are the older generation beta lactamase inhibitors such as clavulanate, sulbactam, tazobactam. However, don't go on this word older. They are still very widely used. These are very important beta lactamase inhibitors. Okay, as well as there are some new beta lactamase inhibitors that are structurally dissimilar from the older generation. How actually they do not have the beta lactam ring in them. Actually, that is how they are different from the older generation beta lactamase inhibitors. But let's not concentrate on that. Just remember this, that there are some older generation beta lactamase inhibitors which are still widely used, such as clavulanate or sulbactam, tazobactam, as well as there are some new ones such as avibactam, uh, bevobactam, and relebactam. Okay, so these beta lactamase inhibitors make our beta lactam antibiotics with some broader spectrum. Okay, so the clavulanic acid, let's discuss this one. It is poor intrinsic antimicrobial activity, means that the clavulanic acid do not have itself activity against the microbes, but it is a very important irreversible inhibitor. It is an irreversible inhibitor of the beta lactamases. That is why it is known as suicide inhibitor. Okay, and it is well absorbed by mouth, and it can also be given parenterally, and it is very commonly combined with amoxicillin. Okay, one more very commonly used is the sulbactam. It is available for IV and IM use. It is combined with ampicillin for IV and IM use, as well as one very important cephalosporin beta-lactam antibiotics, cefpoarazone. Okay. So now let's discuss first beta-lactam antibiotic, one very important beta-lactam antibiotic, penicillin. And you can see here this ring is the beta-lactam ring. Okay, and this beta-lactam ring is hydrolyzed by the beta-lactamase enzyme of bacteria, and hydrolyzation of this ring by the beta-lactamase enzyme is inhibited by the beta-lactamase inhibitor such as clavulanic acid. So the penicillins. Penicillin was the first antibiotic that was used clinically in 1941, and it was originally obtained from fungus Penicillium notatum by the Alexander Fleming. Okay, it was an accidental discovery of one very important antibiotic that saved millions lives. Okay, but nowadays, one very important high-yielding mutant is the Penicillium chrysogenum, which is used for the development of penicillin, that is natural penicillin. And that natural penicillin is the penicillin G or benzyl penicillin, which is not used nowadays so widely, but it was one very important antibiotic of that era. But because of resistance, it is not widely used nowadays. Despite widespread use and increase in resistance to many types of bacteria, penicillin is still a very important drug of choice for the treatment of gas gangrene, which is caused by the Clostridium perfringens, and syphilis, which is caused by the Treponema pallidum. So these two are very important uses of penicillin G still. Okay, but it is acid labile, so it is destroyed by the gastric acid. So we use IM or IV injections of penicillin G or benzyl penicillin or PNG. Okay, but nowadays we have some very important penicillins which are semi-synthetic penicillin. One is the acid resistant alternative to penicillin G, it is penicillin V, and there are penicillinase resistant penicillins such as methicillin, cloxacillin, and dicloxacillin, and there are some extended spectrum penicillins such as aminopenicillins, which includes ampicillin, bicampicillin, and amoxicillin, and there are some carboxypenicillins such as carbenicillin or ticarcillin. There are some uridopenicillins such as piperacillin and meslocillin. Okay, this is one very important classification of semi-synthetic penicillins which you all must know. So let's first discuss the anti-staphylococcal penicillin. Anti-staphylococcal penicillin includes methicillin, nafcillin, oxacillin, dicloxacillin. All these are beta-lactamase resistant penicillins, so they do not need beta-lactamase inhibitors with them because they are already beta-lactamase resistant penicillins, and the use is restricted to the treatment of infections which are caused by penicillinase producing staphylococci, which includes MSSA or methicillin sensitive Staphylococcus aureus. So we use methicillin in those Staphylococcus aureus bacteria which are sensitive to methicillin, but nowadays we have methicillin resistant Staphylococcus aureus, that is MRSA or MRSA. So nowadays MRSA is a source of serious community and nosocomial, that is hospital acquired infections. So they are not very commonly used nowadays because we have MRSA nowadays. They have minimal to no activity against the gram-negative infections. Next one is the ampicillin or amoxicillin, which are aminopenicillins. Okay, these are very important aminopenicillin which have activity against the enterococci as well as bacilli such as Listeria monocytogenes, as well as some gram-negative rods such as E. coli or Haemophilus influenza or Proteus mirabilis or Salmonella typhi. So they have a lot of activity and they are very commonly used. Ampicillin, with or without the gentamicin, is the drug of choice for the gram-positive bacillus, Listeria monocytogenes, as well as some other susceptible enterococcal species, as well as it is very widely used for the treatment of respiratory infections, and it is usually co-formulated with the clavulanic acid or sulbactam. For oral use, we use the clavulanic acid. For IM or IV use, we usually use sulbactam. Now let's see the anti-pseudomonal penicillin, which includes piperacillin. So the uh, piperacillin or piperacillin, which is also referred to as anti-pseudomonal penicillin, it have important activity against Pseudomonas aeruginosa, and it is formulated with the beta-lactamase inhibitor tazobactam. It is very widely used in our hospitals. Let's see the PK of these penicillins. So the PK, we see that these antibiotics which are stable to acid and they are used orally includes penicillin V, because we remember that the penicillin G was acid labile, so it was not used orally, it was used IM or IV, while the penicillin V is acid stable, so it is used orally, as well as anti-staphylococcal. In it, the dicloxacillin is acid stable, it can be used orally, as well as some other extended spectrum penicillins such as amoxicillin plus clavulanic acid, they are used orally, while some are stable to penicillinase, such as all these we know that they are penicillinase stable, as well as these two, amoxicillin plus clavulanic acid, ampicillin plus sulbactam, and piperacillin plus tazobactam, these are stable to penicillinase, so they have some broad spectrum activity. Okay, so route of administration of these beta-lactam antibiotics is basically it is decided by the stability of the drug to the gastric acid, as well as severity of the infection. How severe the infection is in the patient, accordingly we use the penicillins. Okay, one very important point in the PK is the route of excretion. In the route of excretion, we can see that the penicillins are secreted by the kidney by the means of organic acid secretory system. Okay, and this organic acid transporter, it is competed by the probenecid. This probenecid competes with the organic acid transporters, so this probenecid drug, they just inhibits the secretion of penicillins, so they may increase the concentration of penicillins in the blood. So it is one very important point to remember. This star mark, penicillin plus tazobactam and ampicillin plus sulbactam, they are available as parenteral preparations. Now let's see the adverse drug reactions of these penicillins. One very important and easy to remember is hypersensitivity. You all should note that penicillins may cause hypersensitivity, they may cause rashes to angioedema, and in severe cases they may cause anaphylaxis. That is why penicillins are first tested intradermally. Okay, so we do the intradermal testing of the penicillins so that we may know if patient is allergic to the penicillins. If not, then we may use them in those patients. One very important ADR is the diarrhea. All antibiotics actually may cause diarrhea, so it is not very tough to remember ADR. All antibiotics, they have ADR, diarrhea. And in severe cases, they may cause pseudomembranous colitis, which is caused by the Clostridium difficile as well as some other organism. Okay. While one important one area is the nephritis. So the penicillins, particularly the methicillin, have the potential to cause acute interstitial nephritis. That is why methicillin is no longer used clinically. As well as they may cause neurotoxicity, they may provoke seizures in some patients. In some cases, there are some hematologic toxicities which are seen in some patients. They may decrease coagulation, especially high doses of piperacillin and nafcillin. In some patients, they may have cytopenias, so the blood count should be monitored weekly if we are using some longer treatment with the penicillin. One very important to remember ADR is the Jarisch-Hersheimer reaction or JHR. So this JHR reaction, it is caused by the penicillin, particularly in patients with the syphilis. It is nothing but the dying yell of these these creatures. Okay, so what really happens is that the dying Treponema pallidum, this causes the inflammatory cytokines release, and these inflammatory cytokines release causes this JHR, and it is immune mediated self-limited reaction. Okay. So let's see the uses of these penicillins. We know that in syphilis, penicillin G or PNG is the DOC, as well as in leptospirosis, in the prophylaxis use of rheumatic fever. All these are some important uses of PNG. In the respiratory tract infections, including bronchitis, sinusitis, or otitis media, ampicillin is very commonly used. Some other important uses of ampicillin are the meningitis, then gonorrhea, polycystitis, SABE, subacute bacterial endocarditis, that is SABE. So these are some important uses of ampicillin. As well as septicemias and mixed infections, we use IV ampicillin with the gentamicin, which is a very important amino glycoside, as well as acute necrotizing ulcerative gingivitis. It is in this case also ampicillin or amoxicillin is used. But there are some very important points, such as nowadays we use amoxicillin in place of ampicillin because of lower dosage requirement as well as lower incidences of diarrhea. Okay, so lower incidences of diarrhea, it is a very important plus point. That is why amoxicillin is nowadays used, which is given in the dosage of 500 mg 3 times a day, but it is commonly used in addition with the clavulanic acid, which is used in dosage of 125 mg. So 500 mg of amoxicillin and the 125 mg of clavulanic acid, so total 625 mg. So when we saw that the augmentin Duo 625 mg, it is a very common drug which is used against beta lactamase producing resistant Staph aureus but not MRSA, as well as in H influenza infection, then gonorrhea, E. coli, Proteus, Klebsiella, Salmonella, and Shigella infections. Okay, tazobactam is combined with the piperacillin for use in severe infections like peritonitis, pelvic urinary or respiratory infections which are caused by the beta lactamase producing bacilli. Okay, these are our references. Thank you for your attention. Have a good day.